to the stage Anna Bogut. She's a representative from Edis. So Anna, please come here to do your speech, and let's welcome her with one warm applause.
I would like to congratulate the organization team and the organized by this congress. I work as a brand manager in Edis, and this year we are local sponsors. After 5 we'll each other everything there, and after that we also have a workshop so you can see everyday challenges of brand managers in the department. Thank you.
And now we can proceed to our next lecture. So, Ariana Mashtrich, our next speaker is a pharmacist and educator in continuing professional development activities for pharmacists. She's teaching pharmaceutical care and social pharmacy, and is engaged internationally in pharmacy advancement and innovations. After this presentation, participants will be able to understand and discuss new challenges for pharmacists in their new role of dispensing biosimilars, as well as their responsibility towards patients and their therapy. So, Ariana, the floor is yours.
Thank you. I like that sentence, the floor is yours. It's good to have a voice from the community pharmacy sector of our profession. Welcome to everyone, and thank you to the organizers to invite me today to be with you. Coming from Croatia, I think I can say I'm very proud of our Croatian team in organizing such a great event. And after 5 years, again in Croatia, I was also there in Zadar 5 years ago together with my colleague Mike from America, who is with me today. And it's a real pleasure. For those of you who would like to learn more about quality and change, we'll also have a workshop in the afternoon, 3 o'clock, so we can continue talking about the quality of services in pharmacy and how to change it if there is a need for change, and we hope there is. So when I was asked to talk about biosimilars and biological treatment in community pharmacy, I hesitated maybe for 3 or 4 seconds to say yes, because I usually say yes immediately, because it's still quite new. And in Croatia, as in many other countries in Europe, we have been just introduced to a new role to dispense those medications, to educate our patients, and also to take care of them. So I would have to apologize in advance that I don't have more examples from the real life yet, because it's really fresh. In Croatia, it started just before this summer. But I was talking to some of my colleagues last few weeks, trying to be ready for this session. Basically, although my presentation should have a title challenges, they basically told me, yes, there are challenges, but it's basically not a big difference between biosimilars and, for example, insulins that were dispensed for 7 years already. So instead of talking about obstacles, challenges, and gaps, which is usually not my pair of shoes, I like to talk about positive things and perspectives and maybe some opportunities. I will be talking about patient care process and the important points of the patient care process that provide care that we should be careful about and not just skip it for the sake of the patient and for good outcomes of the therapy. So I would like to start with one conceptual triangle. Some of you might have seen it before. It's coming from the International Pharmaceutical Federation Quality Assurance Framework for Pharmacy Education, and it was authored by also Mike Krause and the whole team of people who are working with pharmacy education, saying that we should be ready to introduce changes altogether. So once we have decided that biosimilars will go to community pharmacy, of course, practice was not ready. Of course, we want new roles, but also regulations should be ready to prepare things for us in a proper way. Some standard operational procedures should be in place already. Some instructions, some warnings, maybe some tools should be ready. Of course, FDA have published the famous medical book with the different instructions and everything, but is it enough to make our knowledge ready, our skills ready, and even better, and even most important, our attitudes ready? Because if that's a business opportunity for us, let's face it, that's a clinical opportunity for the patients, and that's also the personal touch that patients really need to find a healthcare professional who will say, biosimilar, not a problem. Sit here with me, I'm listening to your questions, I know all the answers, I will guide you. If there are any problems, you can always come back to me. So, yes, it was a nice moment, but were we ready completely? I would not say so. Education, of course, is an essential part of being ready for something new. So, is education, an e-webinar, which lasts 60 minutes, enough to prepare pharmacists, for example, in Croatia to do so? I wouldn't say so, but this was the only option that we had at that day. Many of us who were attending pharmacy schools 20 years ago or more, never heard about it, of course, and our education was not enough to do it. So you can see that triangle has arrows showing in both directions, which means that what practice will now, after a few months, inform the regulation definitely what's really going on. The practice will now, for example, come to me as an educator and say, hey, by the way, can you please provide a course for our pharmacists because they don't know this or that. And then education will again inform practitioners, and education will definitely inform regulation about the standards that we need and maybe new discoveries that we can find out in science, but they have to be incorporated because day by day we are facing changes all the time. So where are we now? Somewhere in the middle as practitioners, right? But we have a demand, and there's another opportunity that we must not lose. Because if we do it properly, we might get heroes, like vaccinations and other injectable medications we can deliver in pharmacy. If we fail, the system can say, those pharmacists are really not ready, they don't have capacity, they don't have time. And definitely a regulation should assure a payment for such a sophisticated service as dispensing biosimilars. Because having less than €1, for example, in Croatia for that service is a very good strength to talk about with your link. So, let's talk about what it is now and what it could be. Okay, in terms of the patient care, what are the two key words that are coming to your mind? First, patient. What about the patient? If we care about the patient, what we want to achieve? Two things. Cure of the disease. Yes, it will not always be cured, but it should be under control or well maintained. So we say the outcome of medication. We want the result of that. What is the second most important thing in patient care? Patient safety, that's right. Patient safety and patient outcome. Those are the tasks of the pharmacist in the pharmaceutical care, and we have to make sure in biosimilars we achieve both. We can fail if we don't know enough about the application, administration routes, taking care of the storage of those medication and also instructions, adverse drug reactions, but therefore we need to be careful and need to structure the interviews with the patient in a proper way so we find out the important points to take care of it. So, when I was a young pharmacist, Vision 2020 was far from us, but now when you read it, it's actually today. Patient achieve optimal health and medication outcomes with pharmacists as essential and accountable providers within patient-centered, team-based healthcare. This was a statement of all important institutions in America, as you can see. Those guys are great in talking to each other, maybe they don't always agree, but they like to sign great statements all together to be stronger, not in some of our regions we usually fight with each other and we don't want to sign such statements. He's there on the way, things like that. But those guys are very good in coming together and say, hey, let's advocate for the new role. We are an essential part of the team, and we should be the main source of information for everyone, not just for the patient, but also for the doctor, for the nurse, for the nutritionist, and every other person who is in charge of patient care process. Also, there is one concept which was born around 2014, which we like to promote very much around the world. It's now already in our slides and our references, which is called patient care process, and says that we describe a consistent, contemporary, and comprehensive approach to patient-centered care, which means that we don't lose any detail which is crucial either to patient outcome or to patient safety. How is it so? Is it like this? So you can see the nice cycle concept, which starts with the collection of information from the patient or from the other resources that are available for us. And not in all of our countries we have access to the patient record, for example. In Croatia, they're promising us for the last 5 years that they are going to put that click on the patient record, and then we will be able to see other comorbidities, hospitalizations, laboratory values that we are not. We are seeing only the main diagnosis and some of the medication that the patient was collecting in our pharmacy. That's the only thing we see. So of course it's not enough. So we have to ask patients to tell us. Once we know some information that we need to assess them, we need to see the mistakes, the obstacles, and the problems, and the applications, and the errors, and the issues with the patient. Then we have to make a plan which includes patient opinion, patient desired quality of life and their habits, religion maybe, the issues that they might have. We are teaching a lot in the Middle East, for example, in Ramadan time we have to adjust the dosages for diabetes and even for asthma. They're not using the inhalers in Ramadan time, so you have to ask them what is the desired way of life. Then we have to try to implement the plan together with the patient, and then of course to follow up and monitor. Evaluate means already collecting the new cycle, assessing and doing it all over again. What does it also mean? That we need to communicate with others, we need to document things, and we need to collaborate with others. Those are the essential points of patient care with biosimilars, especially because everyone is new in that area. So take a look at another concept which says what are my patient needs. If you want to have a good education, for example, in biosimilars, you have to say why am I doing this education? Why this whole symposium in Poreč is dedicated to biosimilars? Because there is a need. There are patients outside who need proper information, who need proper skills, who need to see you confident in counseling. Therefore, we have to ask ourselves, okay, what kind of services we want to provide in pharmacy? For example, we can use pharmacy for biosimilar medication for the patients. What kind of services do we have? Are we going to make the revision of the therapy? Are we going to make the follow-up visits? Are we going to check up the applications? What are we going to do? And then, what competences do we need to provide those services? Once we know what competences do we need, then we can organize the education about biosimilars. Because we don't want you to leave Poreč with question marks saying, we thought they are going to talk about this or that, but again, we didn't learn what we wanted to learn. We want you to learn today and apply as soon as you can, maybe not tomorrow because you're still students, but as soon as you can to apply it, because once you apply it, then you will know, then you will remember, then you will be more step, and you will change your behavior because of the education. Of course, in case of biosimilars, we can also talk about patient quality of life, because they need to apply certain medication, which, as we have heard from our previous speakers, lots of adverse reactions, lots of uncertainties, lots of biodynamic interactions with other medication, as well as safe, effective, and accessible medications. Why accessible is important? Because those little boxes are very expensive. In some countries, like for example in Croatia, we cannot afford to have it in the storage, 10 packages or packages, because one box costs around €1,000 or 1,300 euros, and in some of our systems we cannot afford to pay those medications in advance, and we wait for the healthcare insurance to pay for us because they wait. And therefore many pharmacists will say, we would like to do it, but we don't have time to afford it. Because wholesale companies will not pay it, they have a strict deadline for us to pay, and what about health insurance? Are they going to be sensitive about those issues? Are they going to be responsible for the continuation of the therapy? We still don't know that, and we're still exploring. And of course, there is a rational, appropriate, and safe use of medication for biosimilars. We can talk a lot about it, so we have to assure that the patient knows about the answers. Trying to prepare for this lecture was googling a lot, of course, and lots of pages are just answering questions. What do you need to know? What do you have to be careful about? What is your problem? So, the kind of inclined, we know your concern, we know you want to know your answer. Of course, production and distribution of medication for these medicines, it's important to get it in the proper chain, also to store it in the proper place, to apply it in the proper way, not to mix up with something else, and also the route of administration should be on a certain angle, on a certain part of the body. It can indicate some pain, some uncomfort, and it's extremely important for us to understand how to educate patients to do it properly. Of course, we have to be there with a stable cycle that I already explained and try to close it and open it all the time when the patient needs it. Of course, those patients' needs and expectations can be only met when we have such a comprehensive process and when we work with others. To achieve the desired therapeutic goals in patients, we have to use therapeutic guidelines based on clinical evidence. As we know, clinical evidence are always very slow to show up in the proper form. And since we are having biosimilars for the last 20 years or so, we're still waiting for the firm evidence in certain cases. So I was trying to look what guidelines are available. I found some of the guidelines which are basically talking about what are we doing in the clinical trials with those medications. As it was already mentioned today, it's quite a famous slide. I'm not sure if someone also already showed you this, but we are not trying to find out are they working or not, but how safe and similar they are to the original product. And this is the guidelines that we are also reading, and we need to know that the clinical evidence is it. Also, we have to remember that we are experts in the field of pharmacy, and we cannot afford ourselves to say, oh, I really don't know, I really have never heard about it, I really am not sure, it's still very new, I was not in the school when people were doing it. So we have to learn as quick as possible, and we have to be a primary source of information, and we hope that the patients will see us as a primary source, because now we have a situation in Croatia, they come from the medical doctors, they say, oh, I already know everything. But what about new patients which will come up maybe next year? First time in pharmacy, from zero. They will start from zero in explanations and in all those questions. Okay, what we should do, we have to control the therapy, we have to assure safe and rational use of the therapy, we have to contribute to the patient's safety, and we have to take care about compliance. Sometimes the patient will hesitate to do the administration of the injectable drugs, for example, and they will ask us to do it instead of them. I talked to a group of pharmacists last week, I provided some education about smoking cessation, and I said to them, by the way guys, I'm going to talk to the students, tell me about your challenges. What is your challenge with the clinical pharmacy? And one lady said to me, the other day I had a patient who was asking me to help with application of the drug. And she says, I was first hesitating because I was not sure, then we opened together the YouTube channel, we were watching together how to do it, and I did it. So she has never had experience before to be educated in this regard, and she was never sure how to do it, but she tried and it was successful. So again, the credibility of the scientific basis about biosimilars are very available, and basically they will lead you to the generic product, or they will lead you to the active ingredient of the drug, and there will be no difference in identifying interactions, adverse drug reactions, or whatever it is. But we have, for example, one example here. If we are going to take a look at, for example, Omnitrop, you will see there is the description of drug-related problem, and all in one look you can easily see what are the adverse drug reactions, for example, fluid retention, edema, developing antibodies, etc. So, and always lead you to the package leaflet or to the SFTC so you can read more. So don't have to worry that you will not find enough information about it. As well, it can be a part of medicine therapy management process, which means that sometimes we need to do some interventions. For example, accept to find more time to work more with the team, to communicate in a different way now, to collaborate with other healthcare professionals. We have to have those clinical competences. Therefore, the clinical aspect of pharmacy profession is very important. What does it actually mean? It means that we have to take care of the interactions, adverse drug reactions, adherence monitoring, and correcting possible medication errors. For example, if you want to read about indications, you can be surprised how one medicine, for example like this one, can treat different diseases. And if you read it for the one medication, you will see inflammatory diseases like rheumatoid arthritis or maybe psoriasis, or maybe you will see, for example, ulcerative colitis or maybe Crohn's disease. So you will be facing one medication with many different indications, which is not always the case with other medications. So it's not easy to read through it quite quickly. Then again, you have to be very careful before you start those medications. And usually the instructions will say what you have to do before you start it and what you should tell to a doctor or any other healthcare professionals who is dealing with your care. As well as, for example, look what is the list, for example, only for one medication of interactions as well, and you're planning your pregnancy, for example, or receiving any vaccines in the future period of time. So many things to take care of with biosimilars, because they usually have quite narrow therapeutic window, and they have many adverse drug reactions if we are exceeding the expected dosage and regimen. Other drug-related problems can be related to the side effects, as we said, again with some comorbidities, allergies, some liver problems, which can then lead to other problems in pharmacotherapy, as well as some possible adverse drug reactions that you then have to report to your medical doctor. So you can also take care of undrug-related problems, and you can see what kind of interventions you can make. You can, of course, talk with the patient. You can, of course, skip the intervention. This is what we call clinical inertia. Clinical inertia is a disease of the healthcare professionals of 21st century. I'm working in community pharmacy. I see the problems, but I think, am I going to get into trouble and now start to do interventions, or am I going to say, I hope everything will be okay. And many times we are using clinical inertia instead of some intervention. So I think we should be more active in this, and we should quit routine in our work. We should be more brave to open the conversation, because the patients are expecting that from us. So, because my time is over, unfortunately, I think this will be my last slide just to conclude and to remind you of some of those stages. Maybe some other time I will be able to explain more about certain stages of the cycle, but please remember, collect the data, assess the data, make a plan, try to implement it, follow up, and document. This is how you will open the new cycle. This is how you will become the safe place for the patient, for biosimilars or any other drugs that can come, they can ask you, and they can trust you for the future. Thanks very much for your attention.
Many thanks for lecture, and I believe with this one we concluded our symposium speakers for the second day, and I think that we can slowly proceed with a panel discussion too. So first I would invite our speakers to panel discussion, so please join us, all of you, and have a seat, and welcome them with a warm applause. Feel free to take a seat, yes. So as we are now slowly moving to a panel discussion, you are completely aware that we're using Slido as yesterday. You were informed to add questions in Slido so we can try to tackle them and answer and bring a bit closer this perspective and fill gaps if there are still some. So we will try to reach every single question that is there and to try to answer and tackle it. Some questions are addressed personally, some of speakers, some are more, as I would say, general, so whoever feels most comfortable can just take the opportunity to answer. So I believe that we can just slowly start. I see one question is, what is your opinion on early market access for experimental drugs, and how can this be improved to be beneficial for patients? Elvira from KPSC Netherlands asked, so maybe someone would like to address this.
I can start. To provide early access to medications that haven't been approved, I think this is a question. And this is indeed in some cases possible, but there are also clear legal regulations and also clear legal restrictions to that. And normally the restriction to that is that no other medications are available which also help to in this special disease. And these legal regulations are of course intended to protect also patients from drugs that haven't been checked in this country and haven't been approved. So yes, early market access is a tool that can be used, but there are very, very clear restrictions, legal restrictions, and it's not always a solution.
Thank you for the answer. I see Mark would like also to address.
Maybe, what does it mean, accelerated approval? What kind of evidences do you get from that drug that passed through the accelerated approval? So you've got just evidences of the drug activity, like response ratio, which we're going to pass through the workshop in the afternoon. You don't get the endpoints that are important for the patient, such as prolongation of the life and the quality of life, and that's meant to be done in the follow-up. However, unfortunately, lots of accelerated approval didn't bring follow-up data after the approval, and sometimes it wasn't the fault of the company, because some cancers are really rare and you cannot get enough of the people in those trials to get the statistical power to prove some endpoints which are rarer than the response ratio of the overall survival. And also in Croatia we have compassionate use. I don't know if you have it in different countries in Europe, where you can get medicine which is not approved for indication, which is in process of approval, or it's approved in another country, we get it for free from the pharmaceutical company for specific indication.
Thanks. I see here one more question from KPSC Netherlands. Here Ellen asks, what is the attitude of doctors towards the identification of the right patients for personalized medicine therapies? We currently have a big project in Croatia regarding genetic testing. It's called Foundation Launch, and Roche financed some of the research, some of the research is financed by the government, so it is getting more and more implemented in the practice. So it just started, so it's quite soon. Okay. And we have one more question from FAS for Romania. So they are willing to hear who, in your opinion, should be in charge of educating pharmacists regarding biological treatments.
I think again we need to collaborate on this. Industry knows a lot. Academia is a little bit slow. Educators who are dealing with continuing education needs to have access to all the information. And I think again we should work together. So what I'm recently involved in is some kind of academias which are organized by industry. I think we should look at those partnerships in a more proper way, not just to think they will promote their products. We have heard nice examples of collaboration between different companies to learn from each other, and I think the industry regulatory bodies, educational institutions such as, for example, professional associations for pharmacists in your country should take care to provide the education on time. In our case, for example, in Croatia, it was a big failure. So, for example, the biosimilars came to pharmacy without proper education in advance. And then we need to, speed up the preparations, and how quality can be compromised if you're doing things too short period of time. So I think it's a responsibility of all of us.
Okay, thanks. Yeah, Maya.
So I would actually like to also add on this question and challenge a little bit. I agree I'm a pharmacist myself, and I think what I was very happy about when I started my lecture, that most of you said you heard about biologics in your course already, and I know EPSA has a lot of wonderful initiatives also on continuous education, and I think that's very important, and it's more and more important in the professional life now when we have this big development and fast development of science. But I want to actually put this question a bit reverse and ask you, what can pharmacists do to educate all of the other stakeholders about biologics? And I think pharmacists in the future can really play a key role in that, because you, in your studies, learn a lot about pharmaceutical development, about biologics, about the analytics and things like this that other stakeholders, physicians, don't understand that well. And I think your role can be to translate this science into the common language that then a patient and others can understand.
I would also like to add a perspective on this educational and very specific sweet spot that pharmacists can occupy. Because I think there's one aspect which we haven't covered, and this is very unique for pharmacists, and this is the aspect of quality, the quality of drugs. Because all of you might have heard about the big problem, for example, of counterfeiting drugs. And I think as a pharmacist, there's a very unique responsibility to ensure the quality of our drugs. And this is also something we need continuous education about. How can we ensure the quality of the drugs that arrive at the patient?
Thank you. And maybe we could just come back a bit, because we have one question that is rolling about, can we expect genetic testing to be included in our healthcare systems in the near future, and how far are we from making that possible?
As I said in my lecture very briefly, the whole intention is to include all the stakeholders in the process of treatment. Okay? So, for instance, my position is that pharmaceutical companies should be included in the risk mitigation for failed treatment. On the other hand, also be very well rewarded for successful treatment of patients. This is something that in the long run will give the incentive for introduction of new medicines and betterment of existing medicines, etc. The third person to include in this risk also is the patient himself. Okay? So there's the whole question of adherence to the treatment protocols from the patient, how this is measured, and again introducing the pharmaceutical company in the process with monitoring of adherence of patients to treatment protocols. Because what we want in the end is to unify the data and the sampling of data on the same way as it's done in clinical trials, to have it the same way in real world data. So it should be the same. So genetic testing in itself should be a part of the treatment process. So predisposition testing and testing during treatment when it's advocated. But predisposition testing will reduce burden financially. Unnecessary treatment or to relieve a patient of unnecessary treatment that is genetically proven that it will not be effective for genetic reasons, and also for, in the end, for introducing new medicines in the future that better address certain patients, which is again colloquially called personalized medicine.
Already nowadays, when we bring new drugs to the market, like drugs in oncology, there's hardly any drug brought to the market where we don't need genetic testing anymore. So the requirement is meanwhile then, if you want to have approval for this drug, you need at the same time a so-called companion diagnostic tool that provides a high-quality test for the biomarkers that are needed to identify the patients for which this drug is best suited. So we have that already today. But I think if we look in the future, we might come to a point where we even have genetic testing in order to also prevent diseases. But I think until we come to this time point, and we ask patients to have genetic testing in order to know what are the diseases they might need to expect when they grow older. We have a lot of ethical debates. We have a lot of data protection topics to discuss, and all these needs to be balanced because maybe not every patient wants to know what are the diseases they are expected to have in the future.
Thank you. I believe that we can also translate one question from Mikhail Kaspar, Romania. So the question is there any way to make it easier for patients with rare diseases to get access to clinical trials?
Recently I was working on the standards of care for the quality, standards of care for breast cancer. And it was mandatory if you want to be a breast cancer center, you need to have at least, I think, percentage of patients included in the clinical trials. So it was sold from the regulatory perspective of the physician society.
I think this is a great question. And I'll tell you how the things are working today. Today, the industry, the different pharmaceutical companies are competing for patients in clinical trials. So what happens is that company A is looking for patients in their trial. So they are trying to recruit patients, and they test the patients and test the biomarkers of these patients, and then they check if they're fit into their clinical trial. Unfortunately, a lot of patients will not fit into the clinical trial. Then company B also tests patients and checks if they're fit into their clinical trials. So we are convinced at Roche, and I think we will share this opinion with many other companies in the FDR, that it would be much better if within the industry there would be a system that we can share the results of those patients, and that if the patient is tested for one trial, then automatically the results of this test are also matching the clinical trials of other companies. And this would really help to better find the patients for these rare diseases, and it would also help the patients to get better access to clinical trials that are really fit to their specific timelines. I think that would be a great progress if we can do this.
Thank you. Yes?
I'll just give a real world example. I my times in the health insurance fund, where we were looking into the rare diseases, the orphan drugs that we were financing at the time with the really, really high costs, and I realized all the costs of research and development, etc. However, when you mentioned the difficulty of finding patients to be included into clinical trials, okay? So there is a rare disease, some deficiency of some enzyme, which is, I think it's 1 in 500,000 people. Okay? So Croatia should have about 20 such patients. We were financing treatment of 76 patients in Croatia. So I was just thinking, okay, it's difficult to find a match of patients to be included, but once the drug reaches market, it becomes very more fluid and much more relaxed on which patients are included into treatment protocols as opposed to those that are included in trial protocols. Okay? So when I put this in front of the pharmaceutical company, asked them how is it the case that we have 76 patients included in treatment with this medicine, and they said, hey, it's up to your doctors that you finance. It's not up to the pharmaceutical company. And I said, in my opinion, this is not an ethical response from the pharmaceutical company. Okay? Bottom line, having 3 or 4 times more patients in treatment protocol than what is according to statistics is something that I think the pharmaceutical company do not act ethically in this situation.
Okay, we made it clear here. Okay, thank you. So we have also one question from Octa from SCP Romania. So the question is, so how long does a patient have to wait between receiving the prescription, the biological drug, and receiving the drug? So since pharmacy has to order.
Usually it's within 1 day, so it doesn't have to be a problem with the wholesaler has it on the stock, and it should be available on the same day or the next day. But also there is a trend in European countries, especially to have like a personal pharmacy or personal family pharmacy, so your pharmacists know exactly what time is your next dosage and what you can expect it to come. There is communication now these days, it's really quick up front, and not to mention the reminders on your mobile phone that can say your therapy is ready for you, so it's, you can come. So I think waiting time is quite short at the moment. The only problem is, as I mentioned, if the pharmacy in general can afford to provide the service or not. So, but basically patients will know if not here, then where they can have the medication in short time.
I would maybe just use this also as a little bit of clarification. I would assume that when we were talking about biosimilar dispensing, we were talking about biological dispensing in general, because I would assume that we dispense certain types of biologics in community pharmacies. And while the majority of biosimilar products that we have in the market are actually in the IV treatment sector, so they would be in the hospital. So in terms of the reaching the patient, it should be immediately in the hospital setting.
In my hospital, we don't have the biologics in our pharmacy. I mean, they dispatch to the pharmacy for a maximum 1 to 3 days, depends on the day of the delivery of the drug to the date when the patient is going to take the drug. Because we all know approximately when is the date the patient should take the drug. It just depends on the wholesaler where it can be delivered. So it's approximately no problem.
Thanks to everyone for answering. We have also one question addressed to Marco. What is your opinion on pharmacists being able to automatically switch to biosimilar without consulting the physician?
The Who asked? Well, we just discussed this issue on the coffee break. I'm going to say just from the perspective of the oncology hematology setting. If we get data regarding interchangeability, which we currently don't do, we got the data from the class with interchangeability. I don't see any issues of pharmacy making this switch. Because the switch is all the application of biosimilar or original drug is going to be performed in the hospital because we don't have subcutaneous biosimilars that want to make switch. We have IV4. When it's applied in a hospital, we have regular follow-up of the patient, so I don't see any issues, but I'm open for a discussion.
Okay, thanks. And one more question, Mike?
I know this question was directed, but I also realized this point before there was one thing that was maybe missing in terms of information is what is interchangeability, what is a switch, and what is a substitution. And I would just like to clarify also these terms. So when we talk about interchangeability, we talk about the possibility to exchange one product for another, and this is kind of an overarching term. And then in Europe, we define also switching and substitution. And when we talk about switching, is with the knowledge of the prescriber. We have everyone in the system involved. And when we talk about the substitution, we usually talk about substitution in a pharmacy level, where the prescriber is not involved in decision making. So these are the terms that I would really like also for you to understand, because you're going to hear them when you will be dealing with biologics. And also, just to mention that in Europe, so I would say that switching and substitution has a lot to do with the practice that we have in different healthcare systems. And although Europe, we have EU, but we have very, very, very different healthcare systems and how they are designed. So this is really goes down to the practice and how things are arranged in the country. But just from the European point of view, at this point of time, we don't have any countries that would actually have automatic substitution in pharmacies.
And then we come to the question, why the US biosimilar market is so small compared to the European market, Mela asked.
It's quite similar, it's quite simple actually, because FDA didn't do so much biosimilars as EMA. It's a matter of regulatory perspective.
So that's the first. Europe was really advanced in this, and they started very early, where there was also a slide on this in your presentation that US approved first one in 2017, but also the patent landscape is different in the US, so there are a lot of products that are available in Europe at the moment that are not yet available in the US, so they are registered but cannot enter the market. So we will see more and more of biosimilars in the US shortly as well.
And how do you think the EU could positively affect biosimilar substitution, or at least drop of prices in member states? And how could we overcome the disparities?
Okay, this is a tough one, and a lot of questions actually in one question. So, okay, so I think in the terms of substitution, as I was saying, it's really related to a lot of factors that are factors related to the country itself. So. And the EU, as I was mentioning with my slides, EU does not have merits to discuss that. But I would also not put this into the same as the drop of prices, into the same category, and to the accessibility of healthcare, how to overcome the disparities. I think these are quite different questions. And I think
we heard in the first presentations that countries actually spend different amounts per capita on healthcare. And we've seen countries that really don't spend so much and countries that spend a lot. But I would also challenge that because we've seen on that graph in the top, very top, we've seen countries like US that spend really a lot of per capita on healthcare, but actually we all know that a lot of things are not affordable to the patient in the US. So that is a challenge I would say with that index. So my question would be how well are actually countries spending those funds that they have and how optimal is their use, and I think that is the real challenge here. So we have many tools. One of them is biosimilars that could help countries to optimize their spending and to optimize how they shape their healthcare systems. But are all the countries doing that? So I think I would rather focus my questions on that. How can actually member states optimize healthcare expenditure and what are they doing on that end?
I think it was key on the slide of the Swedish gentleman that you mentioned, where it says that physicians in Sweden trust the judgment of EMA that biosimilars are safe and applicable in clinical medicine. I cannot say that this is across the board everywhere. I think it's very difficult in a lot of hospital settings to convince doctors that the biosimilar is similar to the originator. It's very difficult. It's a question. If we made a survey here, how many people would, if they were in a situation where they had to be treated, would they be treated with the originator, the reference medicine, or the substitute medicine? It's a very personal question. What would you do if you were in that case? Okay, and Emma says, I'm not using the word generic. So biosimilars similar to generic medicine are proven by regulatory bodies that they are safe and applicable in clinical medicine. Who do you trust? How are you going to do this moving forward? Because once patents run out, once the patent is gone, then as was mentioned in Professor Meshkovich's slide, the Croatian Health Insurance Fund goes through a referencing system where it says the first biosimilar is 50% cheaper than the reference medicine, and then each one that comes onto the list after that is 10% cheaper, and this lasts for approximately 1 year, sometimes 2 years, where we have a referencing exercise that the drug that has lowest price and minimum 5% market share becomes the new reference price. Okay? And even the former original reference medicine has to comply to this price or submit to a co-payment scheme that patients then have to pay the difference to the full asking price. A lot of pharmaceutical companies do this, and they say, okay, we trust doctors and patients to accept our brand as the original and are willing to pay more for this. It comes down to a question of choice, the multi-tier health systems, additional co-payments, insurance, etc., etc., etc. So these are all things that come into play when considering, do we use the original medicine or the substitutes or the new medicines that come into play after patents run out.
Yes, ma'am.
Sorry for taking another time the opportunity to speak, but I think that's a very important note, and what you just mentioned, and for Sweden, really taking the trust, and I think it's a very interesting question, why does this trust work in some countries and in some it doesn't? And I go also back to the Denmark, which is a country in population, for instance, very similar to Croatia. Denmark has 5 million people and Croatia 4 or and in Denmark they managed to switch all the like 90% of patients on adalimumab. And some people then argue when I talk, yeah, but they're different Scandinavians, they have different mentality. But I really question that. Is that really that in other countries mentality is different and you cannot have, I also come from this region, but you cannot have this trust and make systems work. I think it's more of the question, when I was also talking with Danish agency people who were involved in the whole process, they said, yeah, people like to look at you and Denmark and say, yeah, like it was easy for you. No, it was actually not easy. We did hard work for 10 years trying to bring everyone along, educate people, educate prescribers, educate patients, have a dialogue with them, and after that it's what we managed to succeed in that. So I think there is a lot also to learn from each other, from one country to another. And I would also like to say that there are many, many elements of the system that needs to work. So healthcare is quite a complex thing. And there is no silver bullet. As for instance, that question was, is pharmacy substitution going to bring the prices down? So this is one of possible policy interventions, but policymakers actually have a quite a difficult job because they have to make a lot of adjustments to the system and different things to make it work. Because if you don't have trust and you go to to reinforce something, it isn't going to work.
This is a good point, and maybe we can just tackle with other panelists. What would be your opinion and view when it comes to stigma and trust issues? What would be your opinion on the trust issues that we were mentioning now and Maya was mentioning as well? Maybe from your viewpoint.
That's a really beautiful question. We have much bigger issues regarding the trust, etc. And biosimilars and biologic drugs. In Croatia, we have huge issues with the vaccines because of the media, social media that promote anti-vaccination. So we have there is no responsibility in reporting news in the newspaper, and that's actually big issues. Publicity is misinformed, and this is going to be really a bad thing for the future of our society. From that estimation.
Yeah, working with the students, I have a great hope in the open mind is coming on the floor, as you say. And my generation already is a little bit conservative about new things. While I'm teaching practitioners and while I'm asking them to say something, they say, this is how we were told before. So this is still a sentence that I'm hearing at the educational activities. And I think the trust of the patients and medication is starting with the trust of pharmacists in education, in medication. And the knowledge is our strongest weapon about it. Therefore, again, we need to collaborate, we need to open up the issues, the ethical issues, we need to talk about it with industry, with regulatory bodies, within each other, and because this is not our topic. This is the topic of how to treat the patient with a rare disease or with the patient who is not responding to other medication. And we cannot just say, because it's new or because it's not safe, we're going to stay aside. And I think we should teach more about responsibility and about, if I'm not trusting in my medication, then who will trust it? And we need to teach the students about attitudes as well. Because what I'm seeing that my lecture, for example, is at the beginning of the faculty of pharmacy. I'm teaching in split social pharmacy and also at the end patient care. Sometimes I'm seeing my old students coming after 5 years and I say, okay guys, you're going to see the patients in 2 weeks. Are you ready? They say, of course not. I say, why? They say, we don't have the answers. If we ask professors about opinion about vaccination or whatever, they just say, you'll see, this is complicated, there is politics. They want answers. And I think we as healthcare professionals or experts in industry or the administrators in the Ministry of Health, we have a responsibility to give those answers, even if they're not perfect, we have to talk about it. So I think this is a great topic to discuss, and it's an ethical issue.
Thank you.
I also would like to add to that one. Thank you for making the connection between trust and ethical questions, because I think that's really a very, very important connection that we need to make. Because I think also as the companies that are doing R&D, we are always trying to be at the forefront of science and technology. And when we are making great progress, then sometimes the legislation which regulates these new science and these new technologies is lagging behind. So you are in an area where maybe not all legislation is already fixed. And I think, especially in this area, we need to take ethical questions into consideration. And this is exactly what we do at Merck. We have founded our own bioethics advisory panel, which is an advisory panel where we invite experts that are experts on bioethical questions. We have this panel once a year, and we very openly discuss in this panel ethical questions that we have. These are not black and white questions, and these are not questions that we can answer with the existing legislation. And I have to say that this panel helped us a lot to shape our position. For example, on the use of CRISPR-Cas gene editing technologies, on the use of stem cell research, and so on. And I think every pharmaceutical company has an obligation to deal with those ethical questions. Because when you think about ethics, it's not something which never changes, because ethics changes also with capabilities. If I give you one example, gene editing. At the time being, everybody would say to do gene editing in germline, in cells that are inherited, in germlines that are inherited from generation to generation. It's unethical, because we don't have the capabilities nowadays to do that in a way that we are sure that there will be no harm to the next generations or to the patients. In 50 years from now, you might say it's unethical not apply gene editing to patients who have a genetic inherited disease. So we need to be always watching how the ethics develops according to the scientific capabilities.
Thank you for all the answers and all information provided to us. I think that all students in general are very grateful. We have lots of questions to tackle, because there are lots of questions that we unfortunately do not have really at the moment time to tackle every single one of those. But I would encourage you to also approach our speakers, or maybe we can just send to you some additional questions and you can provide us by your opinions, and we can share with students too, so they can be effective. However, maybe we could just make a short wrap up. So what would be from each one of you your key message you would like the students to bring home when it comes to all your perspectives you presented today, in one sentence?
Well, I'm always the first.
Okay, so I'll go first. I'll wrap it up with something that I was trying to do while I was Minister of Health. I was dealing with the emancipation of pharmacists. Okay, I had the notion that people saw pharmacists as a robotic arm that handed drugs from a shelf onto the counter. I wanted pharmacists to be clinical health workers that were an integral part of the health team, together with the doctor, nurse, pharmacist, especially in the area of chronic non-communicable diseases, where cancer is also part of it. So a lot of biological therapies are also included in this. Therefore, please, already at the time of your education, learn as much as you can about clinical medicine. Be prepared to be able to be involved in the treatment of patients, not only with advice, but with an auspices over the patient and his total well-being. Thanks.
Thank you.
Yeah, for me, I would say there is still so much unmet medical need. If you think, for example, of pancreatic cancer, for example, if you are diagnosed with pancreatic cancer, 6 months later you will be dead. So there are still so much unmet medical need that we need to continue to be able to invest in research and development. And we need also to make sure that the innovations which we will achieve in the future will be accessible for many, many patients. And you as pharmacists, you have the really the optimal skills to help to further work on these unmet medical needs.
Thank you. So I hope that in my presentation I managed to shed a light on how biosimilars can also help with the access to medicines and met the need in the areas where there's still, although their medication exists, but it's not accessible to patients. And my main message for you is that I remember when I was a couple of years ago in the EPSA, we were discussing about pharmacy education and knowledge, and at the time we had perception that there is so much more that faculty could teach us and we could learn. But going now reflecting upon this, I would like to emphasize that you have great grounds. You know a lot already, and you have all the possibilities to build on that, to specialize yourself and be really the center of unbiased and trusted resource for all other stakeholders and other healthcare professionals about medicine.
Thank you.
Thank you. What else to add? What's not already said? I would like to remind you on one word that is disappearing from our vocabulary, and it's called serving. Maybe your generation is not used to serve anyone. You guys like to make your own decisions. You like to rule your world. You like to move on without any sense of guilt or answering too many questions. And in a way, I'm learning about how you guys are thinking. But I think serving is such a humanistic part of our profession. And if you will serve the patients with biosimilars or anything else, you will always find the strength and the time and resources to do it properly. I changed lots of things in my career. I traveled the world really, and I have projects in lots of countries. And I think my main treasure that I have is while I was serving the patients when they were having the need. And this makes you soft in your heart, sharp in your brain, and very determined in your progress. So don't forget to serve. It's very noble, and it should be popular again. So please make it happen if it's possible.
I hope that you get the impression through my lecture how I see pharmacists from a clinical perspective as a part of the multidisciplinary team involved in the treatment of various patients in various clinical settings. I see pharmacists as an expert who can provide unbiased and objective information regarding the drugs, and therefore I believe that each pharmacist should have a critical appraisal to provide the new therapies that are coming to the market. They should always make their own research regarding the outcomes that the intervention brings, outcomes that are important for the patients, like quality of life survival and what can they get in specific settings.
Big thanks to everyone for all the messages. I hope the students will bear them in mind and recall memories from time to time. I would also like to greet here Marin, chairperson of this event, since he will be handing to presents, gifts on behalf of EPSA team and reception committee. So yeah, Marin, feel free to come. Big round of applause, definitely.
Okay, hello everyone. I hope you enjoyed your second day of the symposium. So now I would like to thank all our speakers for the insightful presentations and for the fruitful discussion. And I would now like to invite everybody to give a round of applause. First for Marcus Kellen. Thank you. Okay, thanks to our next speaker, Alijana Meštrović. And again, big thanks to our speaker, Maja Ševčić. Next, we have to thank Petra Vikman. And last but not the least, Kristina Shavarda. Thank you a lot.
So, many thanks to our speakers and the panel discussion. I think it was very fruitful. But however, we're still not done. As you know, now comes the place and spot for Symposium powered by young professionals. So what is this? As you know, we as EPSA, we're trying to motivate students to continuously develop themselves, to become lifelong learners, to go outside of their comfort zone, and because this is the only way for them to grow. So therefore we will have now 2 short 10-minute lectures from our 2 participants who would like to present their own experience when it comes to biological treatment. And I will now invite the first one to present here. So Jabir Sandi, he's coming from EPSA UK, and he presented to you his own perspective when it comes to biological treatment. So please welcome him with a warm applause.
Thank you, everyone. Thank you, Martha.
Where is it? Somebody's having perhaps?
So this is going to be a bit different. I know it's 12 o'clock. I know you're all kind of a bit sleepy. But you'll get your kind of green and red cards out, and we'll try to make this as interactive as possible. Yeah, so this is my topic, dermatological toxicity associated with the patinib. Now, it's not a biological treatment, it's actually a small molecular inhibitor, which is slightly different, but they are personalized treatments, and they are highly effective. And I'm going to be looking at 3 or 4, just linked to non-small cell lung carcinoma. So this is just a disclaimer. Now, just a bit about non-small cell lung carcinoma, and a bit about what I'm going to talk about today. Just raise a pair of cards. Who's heard of non-small cell lung carcinoma before? Okay. And who's heard of an EGFR mutation? Yeah. And who's heard of a tyrosine kinase inhibitor? Okay. That's the vast majority of you who actually responded. But those are the 3 main topics I'm going to cover today, as well as dermatological toxicity and how can you manage. So in terms of non-small cell lung cancer, it's actually worldwide one of the biggest kind of causes of cancer deaths. So the World Health Organization actually estimates 2.09 million cases are actually reported, and the vast majority are actually non-small cell lung carcinoma, and they can be further divided into 3 main categories. So adenocarcinoma, squamous cell, which is normally linked to smoking, and also large cell carcinoma. Now, small cell carcinoma, small cell lung cancer, is actually a rapidly dividing cancer, and it's actually quite responsive to conventional chemotherapy such as platinum, gemcitabine. However, non-small cell lung cancer is actually generally quite benign, and it's unresponsive to treatment. So highly personalized therapies are actually revolutionizing the way we actually treat them. So as I said before, so surgery, radiotherapy, and chemotherapy can actually be used to treat these conditions, but a few kind of targeted therapies are now on the market. Prognosis is actually generally poor for these patients, because when they present, they generally present with stage 3B or stage 4 cancer. So the treatment options are limited. But there is good news, and this is on the next slide. Now, I don't think I need to actually explain how positive that is to you, because it explains itself. So, lung cancer, the Lux lung trial actually demonstrated that the median survival with the afatinib was actually 11 months, compared to gemcitabine and cisplatin, which was 5.5 months. Now that's double. And actually, a large proportion of the patients are in that kind of later stage of the kind of trial. And this continues for alotinib as well. So this was for alotinib as compared to conventional chemotherapy, so cisplatin. And again, you can see it's doubled. Now, a thing to note here is that these 2 drugs actually influence progression-free survival, but not overall survival. And the difference is, so progression-free is normally over a short period of time, whereas overall it's over like a 5-year time period. And I can actually explain this a bit more based on my findings from my research. Actually, the best results for these drugs are in the first 2 cycles of treatment. So generally, if you were to plot tumour response against the number of cycles, you would generally get a large kind of response within the first 2 cycles, but then it would kind of plateau, so you get kind of stable disease where tumour death and tumour growth are kind of matching, but then eventually, when you actually develop resistance to these drugs, you can actually get a bit of declining response, and that's generally causes kind of tumour growth. So, as I mentioned before, there are 4 main types of EGFR. You've probably heard of some of these actually. So HER2 is generally used for breast cancer, trastuzumab, but generally there are tyrosine kinase for most of these. So this is a bit about how they work. Does anyone know where a monoclonal antibody acts and why it acts there? Okay? So a monoclonal antibody has to act extracellularly because it can't cross the cell membrane because it's a big bulky protein. However, tyrosine kinase inhibitors, as you can see, can cross the cell membrane, so they can get intracellularly, and they bind to the ATP binding site of the EGFR, and they actually block the molecule from actually dimerizing and actually functioning. Now, why is EGFR important? Well, it's actually important for metastatic growth of the disease, so growth effects, so proliferation, differentiation, and also angiogenesis, actually bringing the blood to the tumour. Now, there are, generally speaking, three generations of these tyrosine kinase inhibitors now. So we've got the first generation, which were ilotinib and gefitinib. Generally, they affected EGFR1. And then you've got afatinib, which is proven to be actually slightly more effective as a treatment. And it actually affects all EGFR, so 1, 2, 3, and 4. And actually, it's used, both of those are used first line in the UK. Now, third generation one is actually used first line in Europe and America as well. But it requires a kind of T790M mutation, which requires further liquid biopsies to actually kind of assess whether the patient has it. Generally, that can be due to poor infusion. If the patient has a chest drain, you can take the kind of sample at the same time and test for ctDNA to actually look for the T790M. So again, this is trying to actually extend to osimertinib, and actually the main kind of gold standard comparison to this trial was ilotinib, gefitinib, and afatinib. So actually, sometimes if the patient's on conventional chemotherapy, it can actually limit whether they receive osimertinib or not. So we need to be identifying patients early, within that kind of stable disease period, to prevent them from actually deteriorating. So in terms of dermatological toxicity, usually it's in the form of mild, as mentioned earlier, grade 1 to grade 2 rash. And actually, it's very easy to treat early on with emollients and antibiotics. And if you treat it early, then you can actually, can have a bit of prevention from actually progressing. It's generally more common in underweight females because due to cumulative exposure of the drug. The general patient, I should have mentioned this before, for EGFR is patients who are 61 years old, Caucasian, Thank you. So, generally, patients who develop a EGFR mutation are actually 61 years old, and they're female, and they're generally Caucasian as well. So this is my research project. We're trying to see if patients developing this highly effective drug, if patients developing a rash due to a better prognosis, due to a better response to the drug. Generally, when you're on this drug, if you develop a rash, sometimes it can lead to cessation of the therapy. And yeah. These are highly effective drugs, so we want to make sure that they're not actually wasted. So we want to make sure that patients get the most out of the treatment. Thank you for listening.
We can now take a seat and we can now call on stage Robert Oakley.
So he's also from EPSA UK. So you can also present your research, and later we will proceed with the questions as well. So let's welcome Robert with one warm applause, please.
Good afternoon, everyone. I'm sure you're being very sleepy. You might need the toilet. I won't be long. So, my name's Rob. I am a rotational Plan 6 hospital pharmacist in the UK. And I'm going to try and give you a crash course about managing biological therapies in practice. And hopefully we can be able to bridge a lot of the gaps that we've seen today into actually translating into the pharmacist's role. Okay? So, that was a great presentation, wasn't it? Is anyone here actually considering a career in hospital pharmacy? Yeah? Awesome, cool. So I'm very recently qualified, so I've been in hospital pharmacy for a year. So 2 years ago I was in exactly the same position as you guys, and was great for my finals to come. So I can talk to you a lot about the end, so please see me afterwards if you'd like some advice or some more information about what I do. Okay, so what I'm going to be talking about is a drug called alemtuzumab, okay? So this is also known as Lemtrada, okay? So, the quick mechanism of action, how does this drug work? So this drug is licensed for MS, multiple sclerosis, and that is what I'm going to focus on today. We can also use it off license in the hospital, and I'll also present you a little case about that. But for the main dosing and mechanism of action, we'll talk about MS. So MS has two components. There is inflammation and neurodegeneration. So this is caused by your T lymphocytes and B lymphocytes attacking your myelin sheath on your nervous endings, okay? So essentially, you can see here we've got the B and T lymphocytes, and then we have the CD52 receptor. So we know that antibodies are like a silver bullet. You essentially target that CD250 receptor, and you aim for that, and essentially by autolysis, these lymphocytes just disappear. And it's very effective. It even goes down to bone marrow level. Okay? So, for those of you who don't know what multiple sclerosis is, we can see on the left a healthy neuron, and then we can see on the right a damaged neuron. So this is as a result of the T and B lymphocytes attacking the myelin sheath. Think about a copper wire, and it has the plastic coating around the outside. Imagine the plastic coating gets affected. It also then, the conductivity of the electricity gets affected, and that's exactly the same in multiple sclerosis. And depending on where it happens in the body, it can cause a variety of presenting side effects. So, the unlicensed version. So, because we're attacking these T and B lymphocytes, we can also use this for cancer. So, what I'm going to talk to you about with this one is lymphomas. Okay, so these are cancers of the T and B lymphocytes. So, in this case in the hospital, we actually use this after someone's had a bone graft from a donor. So you've essentially wiped out all their T and B lymphocytes with chemotherapy, and then we give them a transplant, essentially, of bone marrow. However, it's not that simple. Sometimes the transplant bone marrow causes lymphocytes to be produced that actually attack the body. Okay? So you can see here, it's mainly the liver, bowels, and the skin that it attacks. So the patient that I looked into, you can see here on the right, essentially their skin falls off. It's horrendous. So it's really important that we treat these patients effectively. So how does this drug work, essentially? So you can see here, just before treatment, you get 2 cycles generally, and then up to 4. You can see there's a massive decrease in your T and B lymphocytes, okay? They then regenerate over a 6 to 12 month course. In terms of its kinetics, we give 5 different doses over 5 days for the first cycle, and then 1 year later, we then give another 3 cycles over 3 days. You can see here, so we do a bit of pharmacokinetics, you can see on the right, you're bolstering up the amount of concentration of that drug in the body. So how on earth is pharmacy involved with this amazing molecule? And what happens in the UK? So I've got a little spider diagram here, and there's a huge amount that you can do. A lot of this is actually driven by sort of personal learning. So I've learned all about this myself, just looking into literature, and I feel that's something as pharmacists we need to do proactively and, you know, with the ever-changing landscape. So the first thing I'll start on is counselling your patients. So these are amazing drugs, they do wonderful things, but there are side effects, and these are considerable, like very considerable. So the first thing is autoimmune conditions. 1/3 of patients who get put on this drug will have their thyroid completely, it just plays out. You get hyper or hypothyroidism. So patients need to know that, you know, they're going to get this. We can treat this, but they are going to have a problem. 1% of patients as well, you can also get an autoimmune reaction which completely decimates your platelets. So that stops you from bleeding. As a community pharmacist, it would be very good if you looked into immune thrombocytopenia. Patients will present to you with multiple bruises all around their bodies. And that's because if they've been on a biologic, they have this autoimmune reaction. The second thing, infections. So we're wiping out lymphocytes. So you don't have an immune system. So virtually everyone who's on this gets sort of things from, if they've had herpes infections, they will flare up. And we need to make sure patients are counselled and they're also appropriately medicated to combat this. Next is hypersensitivity reactions. Some people die just from the infusion of this drug. Some people die just from the infusion of any biological drug. You're putting a very foreign body into the system, and the bodies are not like that. There are things we can do to mitigate these risks quite considerably in the hospital, but the patients need to be aware of these risks. Contraception. So generally with these drugs, we don't know that much about long-term effects, but we advise that if a woman is of childbearing age, they use contraception and aren't planning family during treatment. Patient carries alert cards, other professionals are aware of it, and we follow them up. The side effects can persist for up to a year, because it takes over a year sometimes for the cells to replenish. Also, you can see a nice bit of cheese here. It's very important, for example, pregnant women and other people with low immune systems, they're counted on listeria. You and I can eat mouldy cheese and stuff, it's not a problem. If you have no immune system, you will get listeriosis, and again, that can be fatal. So this is actually from a patient at my hospital. As you can see here, this is part of the screening process. So this is essentially a pharmacist checking the prescription, which is electronic in this instance, is safe for the patient. So you can see here, there's a variety of biomarkers on the left, things like platelets, white blood cells, thyroid-stimulating hormone, also things like hepatitis B, etc. So first thing, we want to check, has this patient got any active infection? If they have hepatitis, is it being treated? Is it dormant? If the patient gets treated and they have hepatitis, the hepatitis potentially can be fatal. So we need to make sure they're screened for that and they're excluded because of it, or they're treated. Other bits we've got there. So we've got things about their liver function. There is hepatotoxicity with this. Also, it's not very much in the literature, but there are cardio side effects of this drug. So people are potentially have, you know, some sort of heart deficit before they go in. Make sure you're asking this drug, have you done any ECG? Is there any atrial fibrillation with this patient? Because that's going to drastically increase the risk to this patient. Also, we have supportive meds. So as I spoke to you earlier about listeriosis and other things like that, do they have things like cotrimoxazole? About the herpes, do they have acyclovir? So we're really just trying to make this the safest option for this patient as possible. And we have also things like hydrocortisone, and that's to help with the infusion reactions. So that's to reduce the chance of anaphylaxis. Also at my trust, we have prescribing pharmacists. So once a doctor has made a diagnosis, the pharmacist will actually prescribe the medication. Okay? In this instance here, the patient actually didn't have the correct prescription on the previous screen, they had incorrect cycles. So the pharmacist made an intervention. In this instance, we have a specialist pharmacist that actually prescribes the medication. So as you can see here, they will talk to the patient, they will run through everything, and they will also check and supervise other doctors prescribing those medications. In the UK, if you are competent enough and you have experience, you are able to prescribe medications, and you are a valuable member of the multidisciplinary team. But I must emphasise, this is a very much team effort. So, two other things, guidelines and costings. This drug, for one treatment cycle, costs €60,000. It's not cheap. So it's really important that we actually get the remuneration for the hospital for this. So these type of biologics in the UK are controlled by the central government. They're not controlled by local agencies, and that reduces discrepancies in supply. Sometimes, for example, for the patient I spoke to you about with the graft, that's not licensed, so you can't actually get the money for it. So you have to either apply to the manufacturer, or you apply to the government for like a special request for circumstances. We also need guidelines, because not many members of staff may have the knowledge to use these type of drugs. So there's big pharmacist input into the guidelines that are written, and this is actually part of the guideline at our trust. So you can see there it's part of the inclusion criteria, which NICE generated as part of that guideline. So there's also a technical involvement the pharmacist can have. So the infusion lasts 4 hours, and especially in pediatric patients, you need to have that inside like a saline bag, for example, because you can't give this drug neat. You know, there are some very nasty side effects, including strokes, which have been reported by this drug. And it's also, that's another part of the responsibility to report side effects from this drug back to the regulator. Because we just don't know a lot about these drugs. They're only tried in maybe 1,000 patients before they come out into the world. So I mean, as a pharmacist, you need to be proactive in monitoring this. Also the technical side of things. So you can see the person on the left down there, they're in a lab. They'll make this up, which drastically reduces infection risk on the ward. Okay? And also with storage. When these drugs are kept on the ward, are the fridges calibrated? Are we going to waste 9 grand per vial because the fridge didn't work? Stupid thing to think about, but you know, huge cost implications pharmacists can have. And then we've got the generic sort of supply with this. So it's very important to procure these medications when there are supply issues and ensuring continual supply. And also it's very, you know, as I'm sure you're all aware, when you're checking prescriptions, you have the right product. Okay? So, I appreciate you may have any questions. There's a couple of good slides down the bottom if you're interested in this area or you want to have a further look into things. Alright, thank you very much.
Thank you for the lecture. I would now invite both of you to join me at a kind of discussion, just a short one, like 5 minutes. I know that we are kind of crossing time, but I believe that perhaps some participants are having questions, so let's just hear. Can we see a symbol? I already see one question, so it is addressed to Poreč. So the question is, what is the underlying mechanism of dermatological adverse effects?
Yeah, so that's the thing we're not actually sure about in terms of whether it's immunological or it's, you know, an allergic reaction, whether it's HLA. What I will say is that if it is very severe adverse reaction, I think one patient actually developed a mucositic rash, which was very severe. Within 4 days of actually starting the treatment. If that's the case, then we don't actually think, oh, okay, we can manage this, then we will actually stop the drug. But it waxes and wanes with the cycle, and it kind of decreases and increases in severity, and it's manageable by saying, no, the extent, you know, you can get by. We won't stop the kind of treatment there.
Thank you very much for the answer. We also have one question for Robert. So, how do you monitor the pharmacokinetics of alemtuzumab?
It's a slightly strange question. So I think of pharmacokinetics, you're talking about ADME, so absorption, distribution, metabolism, and elimination. So I guess on that point, how do you monitor the elimination of this drug? Interestingly, there's no information on how this drug is eliminated. We think it's by some sort of endocytosis mechanism, but I think it goes back to monitoring the key parameters for this patient. What is their liver function? What is their renal function? Normal small molecule drugs are usually renally excreted, so we keep an eye on their renal function. As part of this therapy, because we don't actually know how a lot of it is excreted in individual patients, we monitor everything. So we do a baseline of renal function, liver function, ECG for the heart, and then we'll monitor that every month essentially for up to 18 months after they've had the infusion. And that's just checking, because these therapies are very new, we're just doing everything we can to make sure the monitoring is the safest we can for the patient.
And we have one more. In which cases do you exclude treating the patient with alemtuzumab?
Okay, so interesting topic now. So because there's a European alert on this drug, we've had a lot of deaths from heart attacks recently happened, so the EMA has issued a warning. And that goes to the inclusion criteria. So patients on this drug before could have only had 2 relapses of their MS before they actually need to have the drug. Now they need to apply 2 conventional therapies and have had 2 relapses at the same time. Essentially, we don't know why these patients are having heart attacks. We have no idea. So we're trying to look at the data across Europe to see what might be causing that. So we only give it to the patients that really need it at this point. And there's also things with costing. Your different European countries may have different inclusion-exclusion criteria for these patients, as we've found out with the economic picture. Other things is things like, things make sense, like pregnancy. We don't know what's the fetus, so for that reason we wouldn't exclude it.
Thank you, Robert. And there is one question from Shepherd. Could you please specify which exact dermatological adverse effects are associated with the use of the previously mentioned biologics?
Yeah, so generally it's what we term an acneiform rash. Generally speaking, it's mild to moderate in terms of its severity, but as I mentioned before, it can be lymphocytes as well. It can be non-follicular in terms of its pathology as well. So what I'm trying to do is to see whether developing that rash actually correlates to a better response to the drug, and if the progression-free survival is actually better for those patients who suffer moderate rash. It is generally associated with the drug example. What I found is it waxes and wanes with the cycle, so generally speaking at the start of the cycle, patients will develop a rash, but as it kind of goes through their cycle, then it will kind of decrease.
Thank you. Perhaps we can just address one question to both of you. So, how is the UK leading the way in hospital pharmacy?
Yeah, that's fine. I think one way the UK is leading hospital pharmacy is that it's, as Robert mentioned, it's a multidisciplinary approach to healthcare. So I was in a bit of a different clinic that is a similar situation. So there's a drug on the market called Febrafenib, which is for melanoma. What happened was when they were deciding whether to switch the patient or not, the consultant came in, the lead pharmacist came in, and the ward manager nurse came in, and they all had a discussion about what should happen to this patient and whether they should actually make a switch or not.
I think the simple answer to that question is proving your value. Healthcare is changing. We're undergoing a digital revolution. We're going under a biological revolution. And I think, especially in the larger hospitals where there's more resources and expertise available, it's showing the clinicians and patients how we can assist with their therapies. So these didn't exist, 20 years ago. And now we have specialist prescribing pharmacists in this area who are specialists. So it's being adapted to the current social economic climate and also current advances in medicine.
Now, Febrafenib can actually be dosed at once daily, and it's a tablet, so it's very kind of convenient. So what my kind of problem is, so normally patients have to come in to a hospital and actually collect their medicine from the hospital, and now that includes kind of them waiting for hours and hours to actually see a pharmacist or a consultant, and also in that time it takes passing costs for about £30. What my proposal is, so for community pharmacy is a quick setup clinic within the community which are more local to the application, so it's easier cost and time and actually, educating pharmacists and actually providing counselling for the patient.
Yes, sure. Just very quickly to that. So I think with the future of community pharmacy as well, I think what we have to look at is we have an extremely expensive healthcare system, and pharmacists can provide a great way to reduce those costs, and that's where a lot of opportunities in the UK are coming from and have come from. So we're actually looking at having intermediary care centres where we have GPs, nurses and community pharmacists all under one roof to triage patients, and in the future let's talk about referrals from to and from hospitals, so it's working as a whole unit. And I think that's the most important thing, is working with a team. The reason community pharmacists at the beginning didn't have a lot of access and still don't have access to healthcare records is a big issue about trust. You have to have trust between the clinicians and yourself, and once that's established, you can achieve anything.
Okay, great. And maybe just to make a small wrap up with the previous as well, what would be your message to fellow colleagues in terms of injectable biological treatments and how they can be involved and become more active, and what would be your advice in general?
Yeah, so I've got an RXX report on how to actually pick a great research topic and actually implement it as well. So please attend that, and also I actually kind of looked at this myself, like normally in the UK for a master's project we get allocated to the supervisor, so I would encourage you to actually look outside kind of what's offered and meet with a wide range of supervisors and a wide range of mentors, as previously been alluded to in the topic, and kind of just get their perspectives on it. Because what I kind of experienced was I was expected to go into a supervisor meetings with 5 supervisor meetings and get 5 different projects. I was expected to get very similar projects to what I was proposing. But what happened was that I got various different fields of pharmacy. So for example, metabolomics, fluorofactor, integrated with design of protein kinase. So the key take-home message is there are a lot of key areas like pharmacy, and there's a wide range of areas which you can actually go into within, whether it's small molecular inhibitors or biological therapies.
Yeah, don't sit back and let this opportunity pass you because someone else will do it cheaper than you, or they'll do it instead of you. You really need to just, if there's an opportunity, take it. If you have a doctor's surgery near you in your own country and they're using biologics, do your homework, find out more about that biologic. Essentially approach practitioners and say, I have this knowledge, can I assist you somehow? If you're not going to take their service away from them, people are very happy to work with you, especially for patient safety. And pharmacists are a huge resource and safeguard the patients with that safety information. So then, wrap up, do your homework and get involved.